Hi, my name is Jessie, and this is my video presentation for BCIT NSPN 7155 Breastfeeding Experience. I will be discussing the breastfeeding challenges of engorgement in feeding twins. I will work through these challenges by applying the Situated Clinical Decision-Making Framework. The Situated Clinical Decision-Making Framework consists of 5 different components: knowledge, cues, judgments, decisions, and evaluation of outcomes. So let's start with the definition. Breast engorgement is when a mother's breasts are painfully overfilled with milk. It usually is a result of the mother making more milk than the infant consumes. It can occur in the first few days after birth when the milk first comes in, but it can also occur later. Severe breast engorgement can be extremely painful, and when poorly managed can lead to destruction of breast tissue, loss of milk supply, and breastfeeding failure. It is an urgent situation and requires prompt and effective management. Now let's discuss the pathophysiology behind engorgement. With the delivery of the placenta, the hormones estrogen and progesterone drop. Progesterone is an inhibitor of milk production. At this time, prolactin is released from the anterior pituitary gland. It causes milk production and secretion. Once this occurs, the breasts feel full. This is due to them filling with milk and the increased blood flow and fluids to the breast. If there is ineffective emptying of the breast, milk volume begins to exceed the alveolar storage capacity. Capillaries and ducts become obstructed. Fluid leaks into the surrounding tissue and causes swelling. This all leads to breast engorgement. This issue needs to be dealt with promptly, as it can cause a decrease in milk production and reduce milk supply. Also, lymphatic drainage is obstructed and predisposes the mother to breast infection called mastitis. The following is a list of potential causes of breast engorgement: impeded milk flow from breast augmentation or tight constrictive bras, inadequate letdown, smaller breasts. This is linked to the smaller storage capacity, leading to the breast to be full sooner. Small or restrictive feeds. This usually occurs when the mother chooses to have scheduled feedings instead of listening to the infant cues. Abrupt decrease in feeding. This usually happens when weaning the infant from breastfeeding altogether, or when there is an introduction of solid foods. Sometimes the amount of food introduced can be too large, replacing rather than complementing breastfeeding. And the last two causes can be linked with twins: ineffective feedings and separation. Ineffective feeding can occur with incorrect latching. There is a high prevalence of twins being born premature. With prematurity, the sucking reflex may not be fully developed. Another factor affecting latching is the mechanics of feeding 2 infants rather than 1. Mothers may have difficulty properly positioning both infants during feeds. Separation between mothers and infants can occur when premature babies are placed in the NICU. This can cause a disruption in the breastfeeding process. Some signs and symptoms of engorgement are full swollen breasts, pain and tenderness. Now this can extend up to the upper outer quadrants of the breast, just near the armpits. Shiny, tight skin. The engorgement and tightening can lead to flattened nipples, which can further hinder latching. There can be nipple trauma, sensitive sore nipples. There may be an appearance of blood vessels on the breasts, inhibited letdown, and a low-grade fever. It is important to educate mothers on these cues, as it can allow them to seek early treatment. Now, what could be happening? With engorgement, there is clearly an imbalance in supply and demand of milk, so it is important to assess the situation thoroughly to identify the cause. This could be done by asking the mother questions about the breastfeeding experience, as well as observing some feeds. We want to determine if there is improper positioning, a separation between mother and the babies, or an ineffective latch, among other things. Nursing interventions will be based on a determination of the cause. Education can be given specific to the issues the mother is facing. We also want to consider making consultations with other professionals to utilize their expertise in specific areas. We can refer mothers to public health nurses and the breastfeeding clinics, lactation consultants, and physicians. Now, the 3 priorities I have chosen when dealing with breast engorgement and twins are: number 1, feed the infants; number 2, move the milk; number 3, help the triad. We want to ensure that the infants are getting adequate nutrition, whether this is directly via the breast or by expression. Making sure the infants are receiving enough for healthy growth and development is priority number 1. Moving the milk. Since the symptoms are caused by the overfilling of the breasts, we want to remove the milk from the breasts, ensuring that they are empty as possible. This can help to resolve the engorgement and prevent further complications of mastitis and early cessation of breastfeeding. Helping the triad. The steps taken to feed the infant and move the milk will also help the mother and the twins, but we want to ensure that the breastfeeding will continue on for the triad. We need to make sure that the mother and the infants are feeling supported, and the mother has the confidence and knowledge required to continue on with the process. There are some steps that can be taken to prevent engorgement. Frequent feeds. Feeds need to be unrestricted, and parents should watch for feeding cues from the infants. It is best to avoid supplementation, as this does not aid in milk removal. Ensuring proper latch. If this cannot occur due to infant prematurity, expressing milk is a great alternative. Milk expression should be done after breastfeeds as well to facilitate emptying. Avoiding constrictive bras is important in prevention. Appropriate positioning, especially when dealing with twins, is crucial. When feeding twins, the mother can decide whether she prefers to feed the infants one at a time or both together. The benefit of having both babies on the breast at once is that it is an immense time saver. If attempting to feed the infants together, the mother may want to get assistance from another individual in initially positioning the babies until she is comfortable with managing on her own. It may be beneficial to invest in a feeding pillow specifically designed for twins, as it can make the experience more comfortable for all three. Some twin-specific positions are pictured here. There is the double clutch or double football hold, pictured in the top left. This is where each baby is placed on a pillow beside the body with its legs to the back of the chair. Another position is the cradle-clutch combination, pictured in the top right. This is where one baby is cradled with its body facing the mother, and the other is clutched. If one infant has an easier time latching, they should be the one in the cradle position. There is also the double cradle hold, pictured in various ways along the bottom. This is when both babies are in the cradle position with their legs overlapping, making an X shape. The mother should try multiple positions to figure out which is the most comfortable for her and the twins. Now, for treatment. If breast engorgement is present, some actions to be taken are as following. Frequent feedings. We want to ensure milk is still being moved from the breast. Softening of the breast prior to feeds and massage during feeds to facilitate movement of the milk. Expression by pump or hand after feeds or in place of breastfeeding to ensure emptying. Cold compresses or ice packs to alleviate swallowing between feeds. This should not exceed more than 15 to 20 minutes each time and should not be applied directly to the skin as to prevent tissue damage. Chilled cabbage leaves applied to the breast between feeds to decrease inflammation. It is important to thoroughly wash them to avoid introducing bacteria to the breasts or infants. They should not be used more than 20 minutes, 3 to 4 times in a day, as they can possibly dry up the breast and reduce milk supply. Short-term moist heat can be beneficial in eliciting milk letdown. This can be done by taking a warm shower or bath prior to breastfeeding or applying a warm wet cloth to the breast no longer than 5 minutes. And finally, to reduce inflammation and pain, the mother can take non-steroidal anti-inflammatory drugs such as ibuprofen. Evaluation of outcomes. After all is said and done, we want to determine the effectiveness of the actions taken. We can determine this by assessing and asking questions. Is the mother comfortable with the positioning of the infants? Are the infants receiving adequate nutrition? Is the mother experiencing less discomfort? And is the mother expressing desire to continue with breastfeeding? If the issues are not addressed, we may need to reassess and attempt alternate interventions. In summary, breast engorgement can occur shortly after birth or any time after due to various reasons. Having twins presents its own set of challenges that can contribute to engorgement. It is important for mothers to know the signs and symptoms of breast engorgement so that they can prevent or seek early treatment to avoid further complications. Healthcare professionals can help support mothers through these challenges to facilitate a happier and healthier breastfeeding experience. Thank you for listening to my presentation.